In this, we will study that what is the definition of shock, right? What are the various type of shocks, right? Then we will discuss what are the initial primary management of any person coming to us emergency department in shock. Then we have to discuss what are the basic investigations that we have to do for a patient in shock. Then we have to know that what are the management, a general management of patient in shock and management depending upon the type of shock, which we have to do in emergency department itself to save the life of the patient. And then we have to know how to dispose these patients, right? So what is exactly shock? What is the definition of shock? Now, shock is a pathophysiological condition which is due to inadequate oxygen supply to the tissues, to the organs, to meet inadequate oxygen supply to the tissues, to the organs, right? Resulting in end organ failures, resulting in dysfunction of the end organs. So, definition of shock: shock is a pathophysiological state in which oxygen supply to the blood, to the body tissue is inadequate to meet the metabolic demand, resulting in end organ dysfunction, end organ failure, right? So this is the shock, definition of shock. Now, shock may arise due to various reasons. Shock may arise due to, as from the definition, impaired delivery of oxygen to the tissues, right? Impaired utilization of oxygen by the tissues, right? Delivery is less, or delivery is fine, but oxygen is not being utilized by the tissues, right? Increased oxygen consumption of the tissue by the tissue. Now, demand of the tissues has increased. Supply is normal, but demand has increased. Because of increased demand, what is happening? Because of increased demand, the end organ failure is happening. So, shock could be either due to inadequate supply, it could be due to inadequate utilization, or it could be due to increased demand, or it could be due to combination of any of these, right? Now, early recognition of shock and institution of empirical management, right? Institution of starting of initial management is very important to save the life, to save the person from end organ failures, right? So we have to recognize the shock and we have to start the management empirically, irrespective of the cause, irrespective of the type of shock, to save the organ from end organ failures, right? Now, number of times, right, the cause of shock is very evident, like a trauma patient, right? Trauma patient bleeding, or gunshot wound patient bleeding. We know exact what's the reason of the shock, but number of times we may not know the reason of shock, right? But before going and trying to find the reason, we have to start the empirical management in emergency department. So initial empirical management of the shock is very important, right? Okay, so very important, like any other patient presenting to emergency department. ABC: airway, breathing, circulation, right? Followed by a focused history and focused physical examination has to be done. Okay? So a rapid, accurate assessment of ABC: airway, breathing, circulation, a focused history and a focused physical examination to know the cause, and we have to take the action accordingly. So when we are examining a patient in shock, apart from regular physical examination, there are some areas where we have to give more attention, right? We have to pay more attention, which would help us in delineating the cause of shock. So when we are doing the focused examination, we have to do, in general examination, we have to focus on the neck veins. We have to do a very focused cardiopulmonary examination, abdominal examination, extremity examination. This organ examination will tell us whether the signs of hypoperfusion or abnormal vasodilatation etc. is present or not in the patient. Rectal examination is often indicated in case of melena or hematochezia to know the cause, right? To know the cause. So we have to focus on these things, right? So very important. Always in shock patient, right? We have to have two thick bore IV lines, right? Two large bore IV lines. If because of shock the veins are collapsed, the next best place is interosseous line, right? If I'm unable to secure an interosseous line also, we go for central venous line, central venous catheter. It has to be stabilized. We need to have a good IV access or an interosseous access, or we have to put a central line if I am unable to put a peripheral lines, right? Patient should be on monitors, telemetry monitoring. When patient should be on non-invasive blood pressure monitoring to give us the blood pressure of the patient, pulse oximetry, to recognize the end organ failure, end organ dysfunction, etc. Saturation of the patient is dropping, so oxygenation of the organs will not be maintained, right? So continuous, all the vital monitors has to be attached to the patient, right? NIBP, then pulse oximetry has to be attached to the patient. Immediately ECG has to be done and chest radiograph has to be done, because it will help us in delineating the cause. And in shock patient, another very important diagnostic tool is bedside ultrasonography, right? We have to get a bedside ultrasonography done, because this bedside ultrasonography, what we do in let's say in trauma shock patient, something called fast examination, focused assessment sonographically of trauma, sonography for trauma patients, right? We will know exactly what is the cause of shock. We will know exactly what is the site of bleeding of the patient, of internal organ hemorrhage or bleeding. So we will very fast get an idea why patient is in this clinically deteriorated state. Okay, so bedside ultrasonography is invaluable in shock patient. Apart from in trauma patient, it has a huge role even in cardiogenic shock patient, even to know the status of heart. It has huge role in, let's say, in patient with hypovolemic shock. It will tell us about inferior vena cava, IVC collapsibility, whether more fluid can be given to the patient or not, or patient is in hypovolemic shock. We can diagnose by ultrasonography. So it is giving us valuable multiple information for different type of shocks. So it's an invaluable let's say monitor for us. Now we have to start a IV line and we have to, as I told you, we have to secure the IV line and we have to start the IV fluid. If a patient in shock, rarely the IV fluid is bad for the patient, except in cardiogenic shock where they cannot tolerate the fluids, excess fluid, right? So except in let's say cardiogenic shock, most of the cases IV fluid is rarely bad, so start the IV fluid. Now, so we talked about definition of shock. We talked that how do we stabilize a patient in shock, airway, breathing and circulation, what we have to focus during examination of these patients, right? And what we have to do in initial management. We have to start fluid, and what monitors we have to attach, and what during initial stabilization, along with stabilizing airway, breathing and circulation, what are the important bedside investigations we have to do immediately, right? So these things we have discussed. These whatever I have discussed till now is primary survey and initial management of a shock patient. Now I will discuss with you different type of shock, let's say very fast. I will tell you different type of shock and how do I delineate one shock from another, differentiate one shock from another. So first let us talk about different type of shock. Let us start with hypovolemic shock. Hypovolemic shock, decreased in intravascular volume. Now if the intravascular volume is decreased, either due to hemorrhage, loss of blood, or non-hemorrhagic loss of fluid, it will result in hypovolemic shock. Hypovolemic shock would decrease the preload, right? It will decrease the preload, it will decrease the stroke volume, and it will decrease the cardiac output. So when cardiac output is decreased, perfusion will decrease. Now there are so many causes, like for example, hemorrhagic shock, a lot of blood has been lost, right? Heart is pumping, but there is no blood to pump. Patient can go into immediate VF, ventricular fibrillation, or patient can go more commonly in pulseless electrical activity, PEA, pulseless electrical activity, right? Patient can go into pulseless electrical activity if we do not, let's say, replace this blood volume. We do not replace this volume. What will happen? What will happen? Patient has gone through pulseless electrical activity, and reversal from this cause of cardiac arrest will not happen. So we have to immediately restore the intravascular volume. So hypovolemic shock can lead to cardiac arrest, more commonly a rhythm, pulseless electrical activity, rhythm of the cardiac arrest. So we have to very fast try to restore the volume of the patient. Okay, then the second important cause of shock is cardiogenic shock. Now in hypovolemic shock, the preload had decreased, right? Blood volume has decreased. In cardiogenic shock, the problem is in heart, impaired cardiac output secondary to cardiac pump function, or rhythm aberrancy, right? Or structural defect in the heart. So mainly the problem is in heart. Either the rhythm generation of the heart is not happening properly, as in case of ischemia, right, arrhythmias, etc., or there is a structural defect, valvular insufficiency. Heart is not working properly due to valvular efficiencies, or ventricular septal defect, etc., etc., right? Or heart is too, let's say, weak to pump properly, structural defect. So causes of cardiogenic shock: arrhythmias, right? Brady or tachyarrhythmia, cardiomyopathies, MI, that is heart failure, cardiotoxicity from any medication, or structural defect in the heart, that is valvular heart disease, VSD, etc., right? So here the problem is in pump. Then distributive shock, vasodilatation, right? Profound vasodilatation leading to relative intravascular depletion. Blood volume has not decreased, but systemic vascular resistance has marginally reduced. So capacity of peripheral vessels to hold the blood has immensely increased. So what will happen? Again, preload to the heart will reduce because of this immense intravascular volume depletion. What are the causes of anaphylactic distributive shock? Anaphylaxis, right? A primary cause of distributive shock is anaphylaxis. Profound vasodilatation happens in anaphylaxis. Septic shock, another important cause of a distributive shock, because of in which there is a huge decrease in systemic vascular resistance. Neurogenic shock again comes under distributive shock. And toxicologic, any drug leading to peripheral vasodilatation, decrease in systemic vascular resistance, can again lead to the distributive shock. So a vasodilator drug given in overdose, or patient has taken it in overdose, may result in distributive shock. What happens in distributive shock? The pipes, that is the blood vessels, have dilated, so their capacity has increased, so preload to the heart will decrease. Then obstructive shock, heart is fine, the blood volume is fine, the vessels are fine. The problem is heart is not able to perform its normal function because of a impaired, let's say, because of some obstruction. Heart is constricted, or heart cannot pump properly because of some thrombus, etc. in the vessels. So heart can function, but because of some obstruction, it is not able to function properly, as happens in your pulmonary, or let's say a pulmonary or thrombus, in pulmonary thrombus, any cause of any pulmonary thrombus, pulmonary vascular resistance, or coronary artery obstruction, right? The obstructive shock will happen. So pulmonary emboli, your venous air embolism, these are all obstructive cause of shock. Mechanical obstruction due to cardiac tamponade, your tension pneumothorax, right? But your left ventricular outflow obstruction can again lead to obstructive shock. Here again, if we do not discover the cause which is causing this obstruction, we do not treat that cause. A lot of treatable cause of cardiac arrest comes under obstructive shock. Obstructive shock can lead to cardiac arrest. Heart can pump but is unable to pump because of some obstruction, because of some mechanical obstruction, any obstruction. So if we will not remove that obstruction, then heart cannot maintain the perfusion. Patient will go into cardiac arrest. Again the same thing, pulseless electrical activity. Heart is pumping but not perfusing, right? So we have to treat the cause. So these are obstructive cause of shock. Then apart from obstructive cause of shock, we discussed hypovolemic cause of shock, right? We discussed the hypovolemic cause, cardiogenic cause, we discussed distributive shock, we discussed obstructive shock, the 4 primary division of the shock. And apart from these 4, there are mixed condition causing shock, multiple condition, right? Any of above which we discussed, the 4 condition present together, can also cause shock, like carbon monoxide poisoning, right? Endocrine adrenal insufficiency, myxedema, coma. These are because of various reasons, distributive and hypovolemic both, right? In myxedema, coma, environmental, hypothermia, cardiogenic and hypovolemia, both is causing shock in these hypothermic patient. Toxicology, cardiomyopathy because of toxic agent, and vasodilatation causing distributive shock in these patients. So multiple things causing shock, multiple etiologies leading to shock. Okay, so how do I know multiple etiologies leading to shock? So how do I know that patient is in shock due to what reason? So a good history is very helpful in this condition. So after primary stabilization, right, we have to identify the cause of shock and treat it accordingly. So we take a good history of the patient, right? Now in history, we have to see 2 things: the symptoms caused by shock. What are the symptoms which patient is having? It will tell us the severity of the shock and how fast we have to do the management, right? So if end organ failure is happening, we have to quicken our management. We have to be very fast. And another thing which will help by history, to know the cause of shock. So patient in shock may complain of lethargy, weakness, or altered mental status because of poor perfusion. And number of times symptoms are very non-specific, like patient will have chest discomfort, chest pain, dyspnea, right? So non-specific history. Now if patient is in hypovolemic shock, then history will suggest some trauma, hemorrhage. Patient has fell down from height, had a blunt abdominal trauma, someone has hit him on his abdomen. He will give such history of some trauma. Or patient will give history of dehydration, GI loss, or melena, or let's say hematemesis, right? Or female patients, she will complain of vaginal bleeding or very high menstrual flow, something like that. So hemorrhagic shock, hypovolemic shock, hypovolemic shock, hemorrhagic or non-hemorrhagic, patient will give us some lead some history which will pinpoint towards the cause of this decreased volume, right? And we can direct our management in that direction, right? Non-hemorrhagic shock can be due to, in old patient, due to number of times, even due to reasons like decreased oral intake, right? Diarrhea, vomiting, high ostomy output. So all these has to be kept in mind. Patient will specifically may give you these kind of history, or if patient cannot, the person who has brought the patient may give the history of trauma, or history of dehydration, or history of heat exhaustion, anything of that sort. Now, cardiogenic shock or obstructive shock. Patient may complain of chest pain, shortness of breath, edema, peripheral edema, limb edema, or history of syncope, etc. Right? Patient may tell you his etiology, or patient of cardiogenic shock may be a patient of congestive cardiac failure. An old patient, he will tell you about his heart condition. So history would be very suggestive. Anaphylactic shock. Patient will say about exposure of some toxin. Patient will complain, give history of pruritus. Patient may complain of some hives or swelling in the limb, incidental swelling in the limb leading to these features. So in anaphylactic shock, if you take a proper history, maybe we'll get a point of exposure of any anaphylaxis, of any toxin which led to this anaphylaxis. Septic shock, right? Patient will give a history of fever, cough, right? A history of fever, cough, dysuria, abdominal pain leading to all these conditions, right? And number of times it is very difficult to know the reason of the shock. Very vague symptoms are coming, right? But a focused history, we have to focus on two things. First, what is the shock doing to the patient? We have to, as fast as possible, know if any end organ dysfunction is happening or not. And history will help us in delineating the cause of shock. This will again help us in identifying the cause of shock, and also it will help us in our management of shock. Okay, so now on physical examination. Again, after focus history, physical examination should be always be very fast and comprehensive. Okay, now again in physical examination, number of monitors can be attached, right? And some parameters can be detected which will again help us in delineating the cause of shock, right? So number of time, hypovolemia is not only the sole determinant of shock, right? Number of time, blood volume of the patient may be impaired, but the hypotension is not, number of time hypotension is not the sole determinant of shock. If patient is not in hypotension, patient is not in shock. That may not be true. Number of time hypotension may be a late thing. Early body always try to compensate. So never get affected by these things. You always have to focus if end organ damage is happening or not, right? So maybe there would be elevated blood pressure also in shock, can happen in shock. So varied kind of things we can have in physical examination also. So patient may have varied kind of presentation, hypotension, tachycardia, or initially hypertension, tachycardia, then leading to hypotension, or patient has straight away presents with altered mental status, chest pain, etc., the symptoms of end organ failure, etc., right? Then pulse may be thready, pulse, tachycardia, tachypnea may be there in the patient, right? Cool extremities, pale, cool extremities, signs of hypoperfusion, decreased capillary refill, dry mucous membrane, right? Though in a distributive shock, right, peripheries may be warm, periphery may be inappropriately warm compared to the center. So there would be inappropriate warmness of periphery compared to the center. In cardiogenic shock, maybe you can, when you attach the ECG, you can see arrhythmias, right? Edema, murmurs when you will auscultate. JVP distension, jugular venous pulse distension, venous distension, right? JVP distension may be both in cardiogenic shock and obstructive shock, right? So these are the things we will get in physical examination particularly. And focused bedside ultrasonography, I told you, is very important. As fast as possible we have to do this. It will tell us about so many things. It can tell us about intraperitoneal hemorrhage, it can tell about pneumothorax, it can tell about cardiac tamponade, it can tell about cardiac function, the global cardiac function. It can tell us about intravascular volume status. So it can help us in diagnosing the hypovolemic shock, hemorrhagic shock, right? It can help us in diagnosing cardiogenic shock. It can help us in diagnosing, let's say, obstructive shock, right, as fast as possible. Now, vascular catastrophe leading to hypovolemia, hemorrhage, like abdominal aortic aneurysm, can also be very nicely diagnosed by ultrasound. So it is readily identifiable. So again, I will know the exact cause of the shock. So this has become the best tool nowadays in emergency department for shock, in diagnosing or monitoring a shock patient. Bedside ultrasonography, single best investigation, right? Now, physical examination may vary, right? But there are generalized finding. Though this is not a stringent rule, but there is a generalized finding in different type of shock, which I will discuss. I will discuss what is the finding in different type of shock of in hypovolemic, cardiogenic, distributive and obstructive shock on heart rate, central venous pressure, contractility of heart and SVR. So we can differentiate these 4 shock on the basis of these 4 parameters, right? Though it is not necessary that this is a 100% let's say determinant, or in every case of hypovolemic shock this will happen. This can vary, but most of the cases these shocks can be differentiated on basis of this also. So physical examination may vary, but a generalization of the classical finding can help us in categorizing the shock. Now understand a concept of let's say pump, that is pump your heart, the tank and the pipes, So pump, tank, pipes, all 3 has to function properly for maintaining the perfusion of different organs. Pump is your heart. And how is the function of pump? Heart function is measured. Heart function is measured by cardiac output, right? Cardiac output in terms of cardiac contractility and heart rate. So heart pump is working properly or not will determine by cardiac output, cardiac contractility and heart rate. The tank, that is referring to the preload, right? How much the water or blood is in the pump, the heart, for maintaining the perfusion. Tank, the preload. The preload is often measured by CVP, central venous pressure, and the pipes. The function of the pipes is assessed by systemic vascular resistance, SVR. Okay. So based on this functioning of pump, tank and pipes, I can be able to differentiate different kind of shock. Now I will try to differentiate these 4 shock on the basis of heart rate, central venous pressure, contractility and systemic vascular resistance. Now in hypovolemic shock, heart rate will always be increased. Patient will mostly be in tachycardia except in the end stage. Central venous pressure will be low. IVC will be collapsed into inferior vena cava. If I see it in ultrasound, central venous pressure is decreased. That is tank. Tank is not filled properly. Contractility of the heart is increased. Heart is trying to maintain the perfusion, but there is no blood for the proper maintenance of perfusion, and pipe is trying to maintain the perfusion by getting constricted. So as a reflex measure, systemic vascular resistance also increases so that perfusion can be maintained. So in hypovolemic shock, heart rate is more, central venous pressure is decreased, contractility is increased, plus minus maybe increased, but mostly increased, and systemic vascular resistance is always increased, right? In cardiogenic shock, heart rate increase or decrease depending, tachybrady, anything can happen. CVP is increased, right? Heart is not functioning properly, tank is full of, the tank is good, blood is there in the heart, but heart is unable to maintain the contractility. So contractility is decreased and systemic vascular resistance, reflex sympathetic vasoconstriction, constriction of the blood vessels, systemic vascular resistance is increased. So in cardiogenic shock also SVR is increased, right? But heart rate increase or decrease, CVP increased and contractility is decreased. Distributive shock, right? Because the shock of sepsis, peripheral vasodilatation, heart rate is increased, right? Heart rate is increased. CVP is decreased. The tank is not proper because of the peripheral pooling of the blood, because of a huge decrease in systemic vascular resistance. So here systemic vascular resistance is decreasing. Contractility of heart may increase or decrease. Initially it will increase, later on myocardial dysfunction can also happen, but initially it will increase. Okay, so tachycardia will get, CVP is less, SVR is decreased, that is very important. CVP is also less, central venous pressure is also less, and systemic vascular resistance is also decreased. Okay, obstructive shock. In obstructive shock, heart rate is increased. Shock initially there would be always tachycardia except in cardiogenic shock. CVP is increased, contractility is increased, systemic vascular resistance is also increased, but because of mechanical obstruction the perfusion is not there, right? So in obstructive shock, tank is fine, your pipes are fine, your pump is fine. The problem is there is obstruction. So if things are fine but there is obstruction, so flow of blood is not being maintained. So this is not a, let's say, 100% way of diagnosing, delineating these four shocks, but more or less in most of the cases these four shocks, type of shock, can be categorized on the basis of heart rate, CVP, contractility and SVR. Okay. In a lot of studies, right, generally, or in a lot of, let's say, in shock patient, okay, so these four shock can be categorized on this basis. Okay, in shock patient, due to widespread etiology, lot of investigations can be sent to know the suspected etiology, for the differential diagnosis, to know the cause, to know the end organ failure, whether because of the shock end organ failure is happening or not. Lot of investigations has to be ordered, right, to know the end organ failure, right, due to shock, whether the end organ dysfunction is happening or not. Serum lactate is done. Serum lactate is a marker of anaerobic metabolism and degree of tissue oxygen supply and demand imbalance is particularly useful in the initial assessment, right? So if the tissue is not getting supplied by oxygen, then anaerobic metabolism will happen and lactate will increase. So if lactate value is more than 2 milliequivalent per deciliter, then perfusion is not being maintained. So we have to keep it below 2 milliequivalent. Okay, below 2 milliequivalent is fine, but we have to avoid it going above 2 milliequivalent. We have to try to maintain the perfusion. So this is a very useful marker initially for anabolic metabolism due to degree of tissue oxygen supply and demand imbalance. However, no isolated diagnostic test is sensitive or specific for shock. The following tests should be considered: complete blood count, CBC we have to done, electrolyte, blood urea nitrogen, creatinine, glucose, lactate, coagulation profile, liver function test, calcium, urine analysis, we have to see the urine test, ECG, chest radiograph, pregnancy test in female patient, and blood gas analysis we have to done. So these are the lab specific tests. Complete blood count we have to do, basic electrolytes, LFTs, RFTs, coagulation profile, lactate, calcium, urine analysis, ECG, chest radiograph, pregnancy test, etc. has to be done, right? If particular etiology is suspected on basis of these, then further investigation is indicated, like in hemorrhagic shock, right? Hemorrhagic etiology, right? A lot of screening tests are used to diagnose the cause. Infectious etiology, right? Your blood and urine culture, right? So in shock patient, one thing you have to be very clear, that not a isolated diagnostic test is sensitive or specific for diagnosing the shock patient. So initially a lot of lab tests are sent, CBC, complete blood count, then LFTs, RFTs, electrolyte, right, lactate, your coagulation profile, calcium, urine analysis, ECG, chest radiograph, pregnancy test, blood gas, all basic lab investigations are done. Now based on these lab investigations, right, based on these lab investigations, if a particular etiology is suspected, then further investigation is guided by that. Let's say if patient is in hemorrhagic shock, hemorrhagic etiology is suspected, then if a hemorrhagic etiology is suspected, then blood type and blood cross matching etc. is done, because maybe the requirement of more and more blood would be there. So a typing and screening of the blood is done. If infectious etiology is suspected, then blood and urine culture, CSF studies, CT scan, focus CT scan, right, our ultrasound has to be done, right? Then cardiogenic etiology is suspected, then cardiac enzyme, electrocardiogram, echocardiogram. If obstructive etiology, then CT, echocardiogram for pericardial tamponade, etc. And decision to transport a patient out of emergency department to obtain any study like CT we have to do, a radiographic study we have to do, must be very carefully considered. If patient is in decompensated shock, then we cannot send the patient. There, the bedside tool is very important. So that's why I'm repeatedly saying bedside ultrasonography is one of the best diagnostic tool at present we have for diagnosing the type of shock and managing the patients. So if the patient is stable and we are suspecting some particular etiology like abdominal aortic aneurysm or something like that, then maybe I can go for a confirmation by CT. But if my patient is stable, unstable patient should not be moved, has to be first managed for the shock, right? Okay. Timely empirical treatment of the shock patient is crucial to minimize the morbidity and mortality, right? So whenever I get a shock patient, the first thing we have to do is ABC, as I already talked about, right? Airway, breathing first. Now very important, guys. Even if the patient's airway is not compromised, in shock patient, oxygen always has to be attached to the patient, because we need to increase the so timely empirical treatment of shock patient is crucial to minimize the morbidity and mortality, right? So critical findings involving airway, breathing and circulation should be emergently addressed. We have to ensure a proper oxygenation of the patient. So irrespective of the etiology of shock, every patient oxygen has to be attached so that oxygen saturation is maximized. Now airway and breathing. Intubation should be strongly considered for airway protection, optimization of oxygenation and ventilation, and reducing the metabolic load incurred from work of breathing, right? So intubation should be strongly considered to protect the airway, because if patient is in shock, mental status can deteriorate and patient can aspirate, or we may need to intubate the patient for optimization of the oxygen delivery and for proper ventilation, and also for reducing the metabolic load by decreasing the work of breathing. So maybe we need an intubation and support of ventilation. Now, very important that when we are intubating these patients, we have to be very careful, because if you are giving anesthetic agents to intubate them, most of the anesthetic agents are vasodilators. They can further reduce the preload, right, and can deteriorate the shock. So you have to be very cautiously, you have to judge what medication you have to do for give for intubation. And when you are doing positive pressure ventilation in these patients, putting the patient on ventilator and getting a positive pressure ventilation done, then positive pressure ventilation increases intrathoracic pressure, decreases the venous return, and it can decrease the perfusion also. So preload can have a negative effect. Preload can further reduce, so negative hemodynamic effect. So you have to very much optimize the requirement and how much is the requirement, right? Okay, so you have to optimize. Now, in patient with obstructive, this is very important. In patient with obstructive, patient with impaired preload is already impaired in obstructive or distributive shock. So in obstructive and distributive shock, number of times intubation is little delayed, right? Especially in obstructive shock. If we know the cause of shock and immediately manage it, everything can be reversed. So more is towards finding the cause of shock, right? Now, very important, in obstructive shock like tension pneumothorax, immediate needle decompression can solve the problem of the patient. So when we are assessing the airway breathing of the patient, number of times when we auscultate, we can diagnose that patient is having a silent chest, tension pneumothorax, or if an immediate bedside ultrasound is there, I can diagnose that it's a tension pneumothorax, and immediately I have, or by the history of the patient of trauma, etc., I can suspect there is a tension pneumothorax, and immediately a needle decompression is done, right? In septic shock, we have to give more and more fluids and try to optimize the circulation rather than decreasing the preload by intubating the patient. So you always have to optimize according to the shock. Now, circulation. Remember, in shock patient, 2 large bore cannula always has to be put, right? If we are unable to put IV line, interosseous or central line has to be put, right? We normally start with crystalloids as a rapid bolus, right? And remember, in cardiogenic shock is the only condition in which you have to be very careful in giving the fluids. Fluid has to be optimized because it may precipitate pulmonary edema. So we have to give fluid very cautiously. Remember, underlying etiology of the shock has to be aggressively treated. So in hemorrhagic shock, the blood products is indicated, particularly in trauma patient who are not responding to crystalloid. And remember, if in a hemorrhagic shock, huge amount of blood is getting lost and you will replace it by only crystalloid, then it will not have much benefit because coagulation profile etc. of the patient will be impaired, and only crystalloid replacement would not optimize the oxygen delivery. So cause of the shock will remain there. So blood products has to be substituted, right? So if volume resuscitation is not maintaining the perfusion, we are going for aggressive volume resuscitation and is unable to maintain the perfusion, then we can go for inotropes. We can start noradrenaline or epinephrine infusion, because anyhow we have to maintain the perfusion, otherwise end organ failures will start happening, right? Number of times in hemorrhagic shock, surgical intervention is immediately required, because if there is some trauma at some particular site, like femur fracture and massive blood loss is happening from there, if you will not stop that blood loss, whatever you will do, perfusion cannot be maintained. So immediate surgical intervention may be required, right? Distributive shock like sepsis, we have to go for goal-directed therapy, right? Appropriate antibiotic treatment, infection control, etc., which I have discussed in detail in my video on septic shock. So if it is septic shock, we have to manage accordingly. Distributive shock, if I discover it is because of anaphylaxis, distributive shock, then definitely we have to go for adrenaline, intramuscular adrenaline, and if patient is not responding, IM adrenaline. Again, I have discussed management of distributive shock, anaphylactic shock in detail in anaphylaxis. Cardiogenic shock may necessitate the cardioversion in arrhythmia case. Bradyarrhythmia, tachyarrhythmia, maybe we need a synchronized cardioversion or pacing. We need angiography, immediate angiography in number of patients, right? In number of patients, surgical procedures may be required, right? If patient immediate management we cannot do, patient is in cardiogenic shock, then temporary support of the patient like intra-aortic balloon pump or extracorporeal membrane oxygenation may be beneficial. So in cardiogenic shock, according to the etiology and according to the requirement, we go for it, right? Obstructive shock due to pulmonary embolism may require a systemic thrombolysis, whereas cardiac tamponade require an immediate pericardiocentesis, tension pneumothorax, intercostal drain has to be placed, right? We have to do a needle thoracostomy followed by a thoracotomy tube we have to put. So definitive management, we are going towards a definitive management, which we have to do in emergency department itself to manage these patients, right? Adequate resuscitation of shock state is not indicated by any specific endpoint, right, or parameter. I have done an adequate resuscitation. We don't have an end parameter, a specific endpoint, right? But what are the generalized endpoint by which we know adequate resuscitation has been done? Is by blood pressure, normalization of the hemodynamic parameters. Patient's blood pressure has been optimized, patient's heart rate has been optimized, urine output is adequate, right? So more or less perfusion is being maintained, right? Lactate is below 2 millimole per or milliequivalent per liter. 2 milliequivalent per liter lactate means anaerobic metabolism is not high. That is, oxygen is being delivered to the tissues and anaerobic metabolism is not increasing, right? Then the volume status has been restored. Patient volume status has been restored. In ABG, acidosis, etc. is not happening. That is, perfusion is not compromised, right? So once I have adequately resuscitated my patient in shock, patient from emergency department needs to be disposed to the critical care unit for further management, further definitive management, if already a definitive management has not been done in the emergency department. So patient may need to be shifted to the ICU for disposed to the ICU for further management, right? And maybe if other consultation is required, okay?